Hello guys, welcome back to Dr Ranjith, a pathology educator at Unacademy. So today we are going to discuss a single MCQ and a concept related to the MCQ which might open the possibilities of you solving many more MCQs. And this series, hopefully I'll be able to continue in the next month as well. Maybe we'll start 2022 on a higher note and we'll solve more MCQs and more concepts in a tiny short snippets of videos. So it will not take much of your time and we'll definitely solve an MCQ, look at the other clinical possibilities and come to a practical standpoint of view, how you're going to apply it not only in future exams, also in your real life, fine? So if you're ready, and let's start. Okay, so the first discussion today is going to be this question. I'm going to read out the question for you guys and then let's go out through it, right? It's a very big question and it has a superb clinical scenario with and finding of urine analysis as well, right? So first I want you to have a clinical diagnosis based on the history and everything. Then we'll come to the urine examination, any key pointers are there, and then we'll arrive at the diagnosis. I'm not given the options here. Once we arrive at the diagnosis, let's go and have a look at the options, fine. So you look here, it's a 7-year-old boy who came to the clinic with sudden puffiness of eyes. The mother is also concerned about the abdomen distension and which she noticed 5 days ago, right? So first thing is the mom is coming with a kid with a puffiness of face. So this itself gives me a clue of the organ involvement. Which organ do you think is most commonly involved here? That's not a big thing, it's going to be renal, right? So renal related edema, abdomen distension also is possible in renal related edema, not that it should not be seen. Obviously the first one is going to be in puffiness of face, right? So first thing, why do we need see puffiness of face in a renal related edema, right? That has been a thing which I want to discuss with most of you guys. If you look at the perirenal tissue, like periorbital tissue, where edema comes first, if you look at them, if you touch them, they are very soft, they are loose connective tissue. Why loose connective tissue first becomes edematic is the renal related edema, which is due to a colloidal oncotic pressure drop, most likely due to that because of hypoalbuminemia, might not have much enough force to cause an edema in a stronger tissue like your pedal, like your foot, because foot, it's very stretched, it's very strong. Here they are loose, so the possibility of it going to a loose connective tissue, it's just slowly diffusing even in less pressure. That's the reason I'm going to have facial edema first in renal tissues, right? This is one of the proposed criteria. As I said that this is a possibility, so it doesn't mean that abdomen distension shouldn't happen. Again, doesn't mean that pedal edema shouldn't happen. It might lead to anasarca for sure, but the first thing, possible areas, the loose connective tissue, which is around in and around the periorbital tissue, fine? Let's go to the next. The patient had no history of recent infection in the upper respiratory tract. Why this negative history is important for me is, I'm having a patient with a renal possibility, a renal related damage. Few possibilities could be, since it's a kid, chronic renal failure of that sort, diabetes, hypertension of that sort is ruled out. So infection related kidney damage, infection related glomerulonephritis are definitely much more common in this age group. So definitely the negative history of no URI does hold true, does have a real value here to differentiate PSGN or PIGN or even maybe IgA nephropathy. That can also happen in this age group, right? Let's go to the next thing. No respiratory infection or no decreased urination or no gross hematuria, right? So this negative history is not only with my URI, it's also with my decreased urine output and no gross hematuria. So no nephrotic syndrome, no renal failure also. His vaccinations are up to date, fine, great. His vitals include 86 beats per minute, respiratory rate is fine, temperature is fine, blood pressure a little bit reduced, but it's okay. Not so dramatic or detrimental for me here, fine. So his physical examination reveals periorbital edema and abdomen distension with a fluid thread, right? Perfect. So with this history, without going into the lab investigation, what do I think of? What a doctor should think of? I'm having a kid with a renal related cause causing edema. Edema is a primary feature and there is no hematuria. So my first possibility in this place is going to be nephrotic syndrome. I'm going to think of a nephrotic syndrome. A kid with a facial puffiness, everyone is going to think of nephrotic syndrome only, right? So when I think of nephrotic syndrome, what do I need to do to prove it? It's not a clinical diagnosis. It has to be a lab diagnosis only, right? Almost everything needs an evidence and evidence mostly comes from the lab, okay? So to prove it's a nephrotic syndrome, we know the main difference between nephritic and nephrotic syndrome is nephrotic syndrome will not have hematuria. That's there in the history. But again, that alone is not enough. I should also rule out there is no microscopic hematuria also. Sometimes grossly it might not be blood tinged. Microscopy might have a blood. So I'm going to put that under nephritic syndrome only, right? So microscopy I have to see if there is hematuria or not. If it is not, my probability of nephritic syndrome is almost ruled out. Second possibility, to look at the protein excretion, the amount of protein excretion. If it's more than 3.5 grams per day, I'm going to lean towards nephrotic range proteinuria. 1 to 2 grams per day, again nephritic range proteinuria. And albumin, not just albumin, I can look at the urine cast. In the urine cast, if it's cast related, so definitely a renal problem. If it is nephrotic syndrome, I can have fatty cast. In the microscopy, I can have fat. Because when you see nephrotic syndrome, it is not just protein, it's lipid which gets outside. It's antithrombin 3 which gets outside. There are many molecules you can get outside, right? Look at the question, look at the urine analysis now. So obviously the doctor would have advised for an urine analysis, only then he can prove it is nephrotic or not nephritic, fine. Protein is 4+, great, definitely one of the important things. I have 4 grams proteinuria. Creatinine ratios, RBCs are nil, white blood cells are nil, fine. So no infection, no nephritic syndrome. So I have ruled out nephritic syndrome completely. Urine cast, again very important. I'm having urine cast as fatty cast. So I'm having a massive proteinuria. 4+ is not quantitative, it's a dipstick method. So 4+ almost says it's a massive proteinuria. And then I have an serum albumin, which is 1.9 gram per deciliter, which is definitely low. You know that normal serum albumin ranges from 3.5 to 5.5 grams per deciliter, so it's low. Cholesterol levels is elevated. Yes, that's also a feature. So it's not just urine analysis, I have few serum values as well, fine. So creatinine is fine, it's normal, which means there's no renal failure per se. So the positive findings here and the negative findings in the urine analysis, what I'm going to interpret. The negative findings first, no RBCs, no WBCs. I rule out infections, I rule out nephritic syndrome, gone. So only nephrotic is there. What are the positive findings to prove it is nephrotic? Proteinuria 4+, massive proteinuria. I don't have selective albuminuria there, but serum albumin is reduced, so definitely and selective albuminuria is there, right? Urine cast. Whenever urine cast is there, it is something related to my glomerulus, related to my kidney, and not anything down the lower urinary tract, right? So I'm going to think of a fatty cast present. So definitely fat, again nephrotic syndrome. Serum cholesterol is also important. When I say serum cholesterol is elevated, in a 7-year-old kid, I won't think of a metabolic cause of hypercholesterolemia, right? But when you take nephrotic syndrome, you will have lipiduria. As a response to that, it is said that has going to be elevated serum cholesterol levels. It's like two things. There are two schools of thought. One school says that there is more secretion of cholesterol. That's the reason you have lipiduria. Other school says that there is loss of lipid, so you have more increased production, right? It's just the thing which came first, the chicken or the egg, right? So I'm not able to do it, but fine. What finding I'll see is definitely serum cholesterol elevated, right? So again, with all these findings, I can pinpoint and diagnose it's a nephrotic syndrome. Okay, so nephrotic syndrome in a kid, I'm sure I must have made the diagnosis, but there are a few more lines there. Let's have a look what is there. Ultrasound of abdomen, kidney with normal morphology, gross ascetics, and that's all. It doesn't give me any additional values here. So here my diagnosis is nephrotic syndrome. To be specific, my first bet is going to be on a minimal change disease. Obviously, minimal change disease doesn't require a biopsy. I do a steroid treatment trial. If it works, I'm going to say it's a minimal change disease. No one is going to take a biopsy if it's going to respond to steroids. If it's not responding, I need a biopsy. Maybe you'll see it down the road, fine. So this question is based on nephrotic syndrome, and it's simple, minimal change disease. Now let's look at the option. And the question says, which of the following best describes the complication of this boy? So the question is about complication of nephrotic syndrome, not the diagnosis of nephrotic syndrome. Let's go and look at the options. First option, a spontaneous bacterial peritonitis caused by Haemophilus influenza. Spontaneous bacterial peritonitis is an unlikely cause of nephrotic syndrome. If it is an ascites related, if there's a trauma, if something of that sort, yes, I do think of spontaneous bacterial peritonitis. But in a nephrotic syndrome, in a 7-year-old young kid, the possibility of spontaneous bacterial peritonitis is down the road. It's not like impossible. Nothing is impossible in medicine. It's definitely down the road. Fine. Second, urine calcium loss leading to hypocalcemia. This is not a problem. In your nephrotic syndrome, I'll tell you the changes which happens in nephrotic syndrome very quickly. Hypocalcemia, urine calcium loss is not the real problem in nephrotic. It's going to be protein predominantly, and lipid and antithrombin 3 and few other proteins. Almost everything a protein. Antithrombin 3 is a protein. Many proteins go outside. Calcium is not a predominant problem for me, so that will not be the answer. 3. Thromboembolism requiring prophylactic anticoagulation. And I'll put a question mark here. 4. Microcytic hypochromic anemia responding poorly to oral iron therapy. I'll put a question mark here. Fine. Why I put question marks in these two is the first two I can easily rule out. Any undergraduate is going to be able to rule out option A and option B. When I come to option C, It's thromboembolism. See, when you look at thromboembolism, you must have read that in your nephrotic syndrome, I do have loss of antithrombin 3, which is a very, very good anticoagulant. It's a physiological anticoagulant. My body antithrombin, it knocks off thrombin, inactivates thrombin. It also inactivates my protein C and protein S, which is very, very important for me. It's a naturally available anticoagulant. That's also protein. Unfortunately, in a nephrotic syndrome, antithrombin 3 also will be excreted in excess. So definitely there is a risk of thromboembolism in a patient with nephrotic syndrome. That's a known complication. But my question is, let's assume a patient with a minimal chain disease comes to you. You are treating the patient with steroids. Do you think you have to give anticoagulation here prophylactically, or if there is a clot present, I will treat them? What will be the scenario? I don't need a prophylaxis. Without a history of thrombosis, in my question we didn't have any history of thrombosis. If the same question says that the patient has some history of thrombosis documented clinically or by ultrasonogram, imaging wise there is a thrombus, then yes, I'll start anticoagulation, then yes, I'll give a prophylaxis. Without an history of thromboembolism in the kid, in the above history, I'm not going to think of a prophylactic anticoagulation. It is not required. If the patient has a problem, I might treat it and then give follow-up prophylaxis. Without a history, I will not give it. That's the first thing. Second, so this is also wrong answer, right? So A, B, C is wrong, so the only option left for me is D. That has to be the right answer. We have to look why D is the right answer, right? Because that's more important for us. I'll show you a flow chart, which is a very good flow chart to determine what all changes happens in a nephrotic syndrome. Then I'm sure this becomes very easy for us. Just keep this option in mind. It's a microcytic hypochromic anemia responding poorly to oral iron therapy. That's very important. It's responding poorly to oral iron therapy, right? Have a look. See here, you have an increased glomerular permeability. These are the changes that happens in your classical case of a nephrotic syndrome, whatever it may be. There's an urinary loss of protein which carries hormones, metals and vitamins, many of them, because of the increased plasma protein filtration. There's loss of the food process which increases the filtration, so everything goes outside. Altered turnover of immunoglobulins will be there, so that's also a problem. I can have recurrent infections in case of nephrotic syndrome as well, right? So because of this increased filtration of plasma proteins, the patient is going to have albuminuria, lots of albumin loss, right? And increased tubular absorption of the filtered proteins, which results in tubular damage, which can cause a tubular dysfunction as well. Why I want to highlight this tubular dysfunction is, it's not that always a minimal chain disease, creatinine level will be normal. Once tubule is destroyed, creatinine also may become haywire, which means a nephrotic syndrome, though it's a glomerular pathology, because of lots of reabsorption happening. Normally, let's say a tubule is going to reabsorb like 10 micrograms of protein. Here, it's going to absorb like 10 grams of protein. Lots of them reabsorb because everything goes outside. So the metabolism of the tubules becomes more. So definitely they're overworked, there's chance of damage. So I can have a renal failure, creatinine excess in your nephrotic syndrome as well. Keep that in mind, fine? Because of constant albuminuria, what happens is I'm going to have an hypoalbuminemia. It's not only this also is very, very important, right? This I used to ask a question always, because let's think in a different route. See, whatever I'm highlighting the red arrow mark is important for us to understand one thing. I say something as nephrotic syndrome if the amount of protein loss is more than 3.5 grams per day. That's all. 3.5 grams per day is nothing but my normal serum albumin is 3.25 to 5.5 grams per deciliter. So deciliter is 100 ml. So what I'm actually losing is 3.5 grams, which is approximately the amount of albumin present in 50 ml of my plasma. That's all. I have close to 3.5 liters of plasma. I'm just losing 50 ml of plasma's albumin. Can't my liver regenerate? It obviously can. It does more than that on a daily basis. So in spite of losing only 3.5 grams of protein, I'm having so much loss. Like you said, like we always know, glomerulus filter something and 99% of them are reabsorbed by tubules, which means if 3.5 grams is lost, how many grams will be reabsorbed? Lots of them, right? 1% is 3.5, 99% is being reabsorbed. When 99% is being reabsorbed, what happens for me is majority of them will be destroyed in the tubules. There is increased catabolism. The albumin which is reabsorbed will be destroyed in the tubule. That's what is the primary cause of hypoalbuminemia and not albuminuria alone. That's catabolism is a problem here. So it causes hypoalbuminemia. Whatever be the cause, I'm going to have edema due to that. The renal edema, which results in the puffiness of face in the skin, and also the ascites, right? And increased hepatic synthesis of lipoproteins, right? Which causes hyperlipoproteinemia, which causes lipiduria, right? As I said, that this is one school of thought. My albumin is gone, so my liver tries to compensate. It produces all the proteins, including the lipoproteins, which causes your hyperlipidemia, which causes your lipiduria. Some of them say that this filtration itself will excrete lipid, which causes the other, right? So again, there are two schools of thought. I'm not going to the controversy. Both are accepted schools of thought. Fine. Okay. Up to this here, like I said, that there's an alteration in the coagulation factors, right, which causes my thromboembolism, the antithrombin 3, right? So what we are not discussed in this image is, it's not just proteins involving coagulation or albumin. It's also many more proteins. One of the important proteins which is getting lost in your nephrotic syndrome is transferrin. Transferrin is also a serum plasma protein, right? Transferrin is also lost in this process. If transferrin is lost due to a nephrotic syndrome, am I right in saying that there will not be enough protein for me to carry the iron in the serum to the erythroid? It will not happen, right? So it's not an iron deficiency, it's a transferrin deficiency. So transferrin deficiency results to your functional iron deficiency, which causes iron deficiency anemia. Got it? That has to happen, right? So what happens here is, as I said, that there's going to be less transferrin. When I have less transferrin, obviously the iron there cannot bind to it. It's going to cause an iron deficiency anemia. So that was the option D, microcytic hypochromic anemia. If you remember, the following thing was poorly responding to oral iron. This is the cause of IDA here. It's not the iron loss. Iron will not get lost. Transferrin will get caused because transferrin is a protein. Iron obviously is not a protein. Iron will not be lost in urine. Fine. This causes IDA here. So I'm going to diagnose a case of IDA for a patient with a nephrotic syndrome. I'm trying to give iron back. I gave good iron. Good. Let's assume the best iron. Ferrous fumarate has been given. The iron is absorbed in the intestine. The iron stores in the duodenum and goes outside to my serum. If it goes outside to my serum, am I right in saying that there will be no transferrin there? No. So can they bind to it? They can't. So can they go to the bone marrow? They can't. Can they correct the anemia? They can't. Right. So the problem here is not the iron loss; it's a transferrin loss. So definitely, if I give oral iron therapy, the response here definitely will be poor. So the only way to correct this is correct the cause. Only when you correct the cause, this is going to happen. So whatever form of iron you give, maybe parental iron also, I'm going to give iron directly into my circulation. Still, I need transferrin. Without transferrin, it will not go to my bone marrow, right? So the best cause to treat IDA, especially in a long-standing case of your nephrotic syndrome, minimal changes might not be a problem because of a very short-lived disease. I give steroids, predominant of them comes back to normal. In a long-standing case of IDA, you have to treat in nephrotic syndrome, you have to treat the cause, right? That's very important. That's what led to this question. Fine. Great. So we have come to the fag end of today's discussion. So just to have a quick recap, what we saw here was a case of a nephrotic syndrome with minimal change disease. We had the differential diagnosis based on the clinical history, which is absence of hematuria and your your ascites and your facial puffiness. We thought of a nephrotic syndrome. We saw the urine analysis, we saw the serum analysis. We concluded it's a nephrotic syndrome. We confirmed, and we saw the options. Two of them we easily ruled out. Thromboembolism requires prophylaxis or treatment only with a history. Without an history, I am not going to give prophylaxis in case of nephrotic syndrome. Do remember them. Fine. Next, obviously, we saw about your microcytic hypochromic anemia. Why it happens? Because transferrin is also a protein which is also lost in your nephrotic syndrome. In addition to your lipiduria, in addition to your albuminuria, in addition to your antithrombin loss, in addition to your immunoglobulin defects. Right. So all of them are surrogate find evidences along with your transferrin loss. Okay, great. So hope we had a good time. So hope we will learn more together like this. I'm going to take one MCQ. I'm going to learn detail about that MCQ. The purpose of these short videos are not to crack an MCQ. That's not my primary motive. To learn what is there surrounding that MCQ. So if you learn in depth, it's not only this MCQ. I can have any MCQ coming in nephrotic syndrome. You should be in a position to answer them. That has to be the goal. So rote learning, you just learn by a point, a fact, a mnemonic is not going to be useful for a next or a NEET pattern of examination. or be it INACET, right? I want everyone to have a conceptual understanding of the topic. Once you understand the topic, whatever MCQs comes on the topic, whatever is being thrown at you in the exam, you'll be able to think logically and you'll be able to solve. Hopefully in future we'll be able to learn more about them, fine? And there have been 10 series of IBQs in the form of special classes, which is there in the Unacademy app. You can follow me in the Unacademy app, Dr. Ranjith at Pathocubs, and you can see all of them, right? So the link to download the Unacademy app will be there in the description below, and all of them will be special classes which are going to be free for you guys. Thank you for your time. See you soon. Till then, bye from Dr. Ranjith. Bye.